ladies and gentlemen. I would first like to thank the organizing committee for inviting me to Egypt, a country where I have spent an important part of my youth, and I perceive it as my second home. And I hope that nobody will ask me questions in German because I'm not from Germany. These are the 6 objectives of the Global Action Plan to control non-communicable diseases, and these objectives have been accepted by the World Health Assembly, so all countries have agreed to this Global Action Plan. And it provides a kind of roadmap for actions which, if they're performed collectively by the countries, by the UN, by WHO, NGOs, and the private sector, will achieve 9 global targets for NCDs. Dr. Margaret Chan, the Director General of WHO, said, what gets measured gets done. So it was decided that the countries will take on a number of tracer targets and focus on the 4 major contributors to morbidity and mortality, the 4 major non-communicable diseases, of which diabetes is one. And achieving these targets would mean a major contribution to the control of non-communicable diseases, and the target date was set to be the year 2025. So the global monitoring framework includes 25 indicators. There is the indicator of mortality and morbidity, risk factors like smoking, physical inactivity, salt intake, and the national system's response, which includes access to medication, access to essential technologies, and care. The targets of these indicators are 9. There is an overarching target, and countries will try to achieve a 25% reduction of mortality from non-communicable chronic diseases. And there are some targets that are directly or indirectly related to diabetes, like essential medicines and technologies access, drug therapy and counseling for at least 50% of people who need it, who are at high risk of a cardiovascular incident, and diabetes is one of the risk factors. Diabetes and obesity, a 0% increase, control of blood pressure, and then physical inactivity also related to diabetes. And the criteria for selecting these targets are that they are of public health importance, they're coherent with major strategies, that there are effective and feasible interventions, and that there is evidence that they are achievable at the country level, and that it is possible that there are means of measuring them. 25% reduction of premature mortality, that has been said because there is historical experience that some countries have managed to achieve that, so it is set to a 2% reduction per year. 80% availability of both public and private facilities of basic technologies for major chronic diseases. This has been achieved in many low and middle income countries for vaccines, TB, malaria, and HIV treatment, so it should be possible to be done for non-communicable diseases. People who are at high risk of a heart attack or stroke typically do not receive prevention, lifestyle intervention, nor pharmacological treatment in many developing countries. It is possible to reduce the risk of cardiovascular disease, of premature cardiovascular disease, and so this is one of the targets that we're aspiring to. It is possible to reduce the population physical inactivity by at least 10%, because some countries have managed to do it. It is possible to reduce blood pressure in the population. It is possible to reduce the harmful use of alcohol. It is possible to reduce the number of people that smoke. And also, some countries have achieved a 30% reduction in sodium intake, so this is also a possible target. Now, the diabetes target is a slightly tricky one, and it came in at the last moment as an inspirational target, because this is the only target that the achievability is doubtful, because nobody has ever succeeded to do it. Nobody has reduced the prevalence of diabetes. There is some data indicating that childhood obesity is not going up anymore, but it's certainly not going down anywhere. And the achievability is doubtful because as populations age, naturally glucose metabolism deteriorates, and we are all getting living longer and longer. So this is a very inspirational target. It is unlikely that it is actually going to happen, especially if we will keep people with diabetes alive longer through the improved access to treatment. So the core functions of WHO where I work are these 6, but for the purpose of my presentation, let's take the target, the function of setting norms and standards. And I guess you're all familiar with all these publications, which are all diagnostic criteria for diabetes, and which include various recommendations through time. And in 1991, the technical report included its definition of gestational diabetes. And now it is, last year we have published the update, and we have called it Diagnostic Criteria and Classification of Hyperglycemia that is first detected in pregnancy. So we formed a consultation, and the questions that we asked are how to classify this hyperglycemia first detected in pregnancy. Is detecting gestational diabetes worthwhile? We looked at the association between hyperglycemia in pregnancy and certain adverse outcomes. We looked at the magnitude of increased risk of adverse outcomes with the 99 criteria and the IAD-PSG criteria, which had recently, before that, come out. And we looked at the question of whether treatment for gestational diabetes can reduce adverse pregnancy outcome. And if we conclude that diagnosing is worthwhile, which diagnostic procedure and criteria to use? So we retrieved some evidence and synthesized it. The first systematic review was to relate plasma glucose and pregnancy outcome as defined by these 2 criteria. The second was to conduct a systematic review on the effect of treatment of GDM on pregnancy outcome. And the third, we conducted a simulation study to see what would be the impact on the population if systematically all pregnant women were screened for GDM, and if they were treated, all of them were treated for GDM, if they had it. For judging the quality of the evidence and for formulating the recommendations, we used a grade system which is now used by many authoritative bodies that issue guidelines, bodies like SIGN in Scotland or NICE in the UK. And it's becoming much more popular and used throughout the world. And in this system, the quality of evidence is graded as high, moderate, low, and very low based on the characteristics of the studies that you find for the question that you are asking. And then for formulating the recommendations, you say it's either a strong recommendation or a weak recommendation, either for an intervention or against an intervention. So what was the risk prediction? What was the relationship between blood glucose levels and large for gestational age babies? And the systematic review showed several studies from which this could be deduced, and it is both in IAD-PSG criteria and WHO criteria. The blood glucose level is a good predictor of large gestational age of the baby. For perinatal mortality, it looks like glucose is somewhat linked to a higher perinatal mortality, but the results were not statistically significant. What about mother's preeclampsia? In both WHO 99 criteria and IAD-PSG criteria, women with gestational diabetes had a higher risk of preeclampsia. Prediction of cesarean delivery, again, in both sets of criteria, women with GDM had a higher risk of cesarean delivery, but that could also have been because of elective cesarean sections, not necessarily emergency ones. So the conclusions from this systematic review is that the 99 criteria and the newer IAD-PSG criteria, they both identify women who will have a higher probability of some adverse event in pregnancy or immediately afterwards. Large babies, preeclampsia, and cesarean section. And here you see the quality of the evidence. And although the risk of perinatal mortality is increased with both criteria, the increase was not statistically significant. And none of the studies reported any maternal mortality, so we do not know what the outcome of such a pregnancy is for the mother. Systematic review number 2, what is the effect of treatment of gestational diabetes on pregnancy outcomes? So these are the studies that have been selected as suitable for the systematic review. And as you see, they don't all have the same criteria for defining gestational diabetes. This study used WHO criteria. The earlier studies actually had women with higher glycemic levels. So it's a kind of mixture of various studies through a long period of time. And this is the effect of treatment on perinatal mortality. It does look like treatment lowers the risk of perinatal mortality, but this was not statistically significant. Effect of treatment on large babies? Yes. Treatment reduces the risk of having a large for gestational age baby. What about shoulder dystocia? Again, yes. On preeclampsia, yes, treatment reduces the risk of preeclampsia. Cesarean section, not significant, no particular effect. Now, does it make babies smaller? It does not. It does not. Does treatment risk preterm delivery? From this data, we cannot say that it does. So the conclusions is that treatment can prevent macrosomia and large infants, can prevent shoulder dystocia, and can prevent preeclampsia, and the only high quality evidence is for macrosomia and large babies. And no statistically significant reduction in perinatal mortality or cesarean section. And there is moderate quality of evidence that it will not make small for gestational babies and not cause preterm delivery. And there is no direct evidence that the impact of screening strategies on adverse pregnancy outcomes, but there is indirect evidence that screening can prevent preeclampsia and large birth, but the numbers needed to screen are large. And the screening strategies with these criteria may prevent slightly more outcomes than the older WHO criteria. However, more women require treatment. So the recommendations of the guideline are that hyperglycemia first detected at any time during pregnancy should be classified either as diabetes mellitus or as gestational diabetes mellitus. And for defining diabetes, we use the WHO criteria which are used for non-pregnant adults. So nothing different for women who are pregnant. The recommendations for defining gestational diabetes is that it should be done any time in pregnancy if one or more of the following criteria are met. So this fasting plasma glucose, either this, or this. And this is the first time that the possibility is given for identifying women with GDM by fasting glucose. Between IAD, PSG, and WHO, there is a slightly difference in terminology. The WHO calls it diabetes in pregnancy, and IAD-PSG calls it overt diabetes. And the new diagnostic criteria are based on the association of plasma glucose and adverse maternal and neonatal outcomes during pregnancy, at birth, and immediately following birth. And in the interest of moving towards universal diagnostic criteria, the WHO recommendations are the same as those of the IAD-PSG, but there are some modifications. Unlike the IAD-PSG, WHO criteria have a range of plasma glucose levels to distinguish diabetes from GDM. So now we have two categories. We have the real diabetes and we have the mild hyperglycemia, which is not so deadly or dangerous. We don't know about long-term consequences enough. So we think that the new criteria are clearer on the use of fasting plasma glucose. And if we use the new criteria, this is an estimate, and that is the worry of some policymakers that the prevalence of women that will have something wrong with their glucose metabolism in pregnancy will increase by 53% if every country adopts these new criteria. But we actually, for gestational diabetes, with the mild hyperglycemia, we don't really know how much of the burden of obstetric complications can be attributed to hyperglycemia. And we don't know how much of the future diabetes and obesity we could avoid if we treat rigorously every diabetic and non-diabetic hyperglycemia in pregnancy. So what proportion of obstructed births can be attributed to hyperglycemia? That is for the obstetricians and diabetologists to answer this question. So this would be an interesting research topic. So if you have some nice data, please do publish it, and that will be used for a future update of the guideline. What proportion of large babies can be attributed to hyperglycemia? What proportion of hypertensive disorders can be attributed to hyperglycemia? And if we look at the maternal mortality data from every region, including this region, maternal mortality is going down, despite of the fact that there is a rise in the number of women with diabetes. And similarly for neonatal mortality, the neonatal mortality has been reduced in this period in all regions of the world. And the answer to the question of how much would we reduce the burden of large babies or the number of women with preeclampsia if we screened every woman. If we screened every woman who was pregnant and treated every woman that was diagnosed with the same effect as was achieved in the clinical trials, we will reduce the percentage of large births only by 0.91%, preeclampsia only by this much, which indirectly shows that most of the burden of large babies and preeclampsia actually occurs in women who are normoglycemic. Thank you.